We hope to have this up on our website in the next week or so. I'd like to introduce today's speaker, Dr. McLean. Dr. McLean is an assistant professor of medicine in the Division of Infectious Diseases at New York Presbyterian Columbia University Medical Center, where he completed his infectious disease fellowship as well as additional research training devoted to HIV prevention and sexual health. He now provides clinical care in these areas through New York Presbyterian's Comprehensive Health Program and Project STAY, and serves as faculty for the New York City STI Prevention Training Center. He also responds to many of our STI consults via our CDC STI Clinical Consultation Network. So welcome, and thank you so much for your presentation today.
And thanks so much for the introduction, Gowrie, and thanks to everyone for being here. I really appreciate the turnout today. And so this first slide is just to, again, sort of celebrate STI Awareness Week and linked out to some of the resources that CDC provides for clinicians for this. And those include some guides to sexual history taking, guidance around STI testing, as well as the 2021 STI treatment guidelines, all of which I found exceptionally useful and would recommend unconditionally. Like Gowrie said, the topic of today's talk is syphilis. I kind of think of as the return of a classic, mostly because syphilis is an essentially ancient infection that goes back to kind of the beginning of recorded history. And something that, despite advances in testing and therapies along the way, unfortunately, we're really still grappling with. The standard disclosures at the beginning here, I have nothing to disclose financially. And to go through the objectives of what we're talking about today. So we'll start out talking a little bit about some epidemiology to recognize the burden that syphilis poses today in the US. We'll spend a lot longer going through the stages of syphilis infection, and then talk about how to interpret testing. We'll then finish up by determining appropriate syphilis treatments based on stage, and summarize some recent changes in the 2021 guidelines. There are a number of things we won't cover. So congenital syphilis is really a big topic that deserves and will get its own discussion tomorrow with Jason Zucker. We'll touch only briefly on syphilis in pregnancy, which has some of its own requirements for testing and treatment. And we won't really talk about some of the really late-stage syphilis manifestations like syphilis dementia, all of which are also fairly complex and something that most practitioners will encounter a bit less commonly. Finally, we won't really talk about syphilis prevention, especially doxy-PEP, as that's a pretty new intervention and, again, deserves most of its own talk. Finally, today, because there's so much to cover, we'll be moving pretty quickly. And while I usually like to have some kind of questions to check understanding and keep everybody engaged built into these talks, we're going to omit those for now. But I would encourage everyone to come to the third talk in this series with Dr. New, who's going to go through some syphilis cases.
And Dr. McLean, just a quick thing. I think the cursor is actually moving around the screen a little bit for some reason. I don't know if that's on your end or not.
We'll try to.
Oh, perfect. We don't see it anymore. Thank you.
Okay. And so this slide just comes from the 2022 STI surveillance report from the CDC, and just kind of underscores the point of the burden that STIs pose in public health today. And so you'll see that all kind of STIs are on the increase, and that chlamydia and gonorrhea represent sort of the largest proportion of this. Syphilis has really had the steepest increase, especially over the last decade, including cases of congenital syphilis, which is sort of the really most unfortunate outcome that we can see here. Going back in time just a little bit, syphilis started becoming a reportable disease in 1941, and then penicillin really became widely available standard therapy in about 1944. And you can see the steep decrease in cases that follows that. In the 90s, there was another kind of epidemic in the US and an increase in cases there that kind of got a pretty robust public health response, followed by a decrease in cases in that time to essentially the historical nadir in the US. And after that, we saw kind of a spike in cases like we just discussed. But it's just worth pointing out that it wasn't always, or it didn't necessarily have to be that way. There was a moment there after that decrease in the 90s where there was optimism about essentially eliminating syphilis as a pathogen in the United States. And the report that you see here kind of notes that, the testing exists, the treatment exists, and sort of if we can sufficiently increase people's access to those resources, we really should be able to get rid of this infection completely. Unfortunately, of course, that is not what happened. And so this is a chart mapping the increase in, this is primary and secondary syphilis since the year 2000. And you can see we've really been on a steep and getting steeper trajectory essentially since that time. And so what do we do about it? And again, this is STD week. And kind of the theme that STD week is kind of built around, and the way that I'll try to structure this talk is about talking, testing, and treating. And so we'll start with talk. The majority of syphilis cases that you saw in that surveillance report, and the majority that are diagnosed, are actually asymptomatic cases. And so knowing who to offer testing is really critical to kind of uncovering those cases and getting people the treatment that they need. And so getting that sexual history and thinking about who might have a higher risk of infection is really critical. The CDC offers a guidance on sort of who to test for syphilis and who to screen specifically. And so this is a slide regarding kind of the screening recommendations. You'll see that men who have sex with men are recommended for at least annual testing if sexually active, and potentially more often if increased risk is present. The recommendations for transgender and gender diverse people are similar, at least annually and more often as needed. People taking PrEP should get screened at initiation and every 3 to 6 months thereafter, again, if increased risk. And people living with HIV also at diagnosis and at least annually if sexually active. The recommendations for non-pregnant women, cisgender women, and non-MSM men don't mention sort of routine screening intervals, but does note screening asymptomatic adults who might be at increased risk. And then pregnant women have routine screening at the first prenatal encounter, and then the 3rd trimester as well. And then again at delivery if there's this concern for increased risk. You'll see this phrase increased risk mentioned so many times here. And sort of the point of including this, I think, isn't to stigmatize folks by sort of trying to pin down specific sexual behaviors and things like that. But the CDC does mention a number of kinds of factors that might prompt more frequent screening. Among MSM, that every 3 to 6 months, they specify kind of folks who have multiple or anonymous partners, and you can kind of extrapolate that to folks in any of these other categories. People under the age of 29 are specifically there, people who use substances in the context of sexual encounters, especially methamphetamine. And so this is something that can be sort of, situationally dependent. But always it's sort of, these are the baseline screening intervals. And then if anything, people can just be screened more frequently. Okay, going back to our algorithm. So we've talked about sort of who to talk to, what kind of information you want to get to think about screening for syphilis. And now this would have us move on to testing, but I would submit that there's actually sort of a missing item here in this sequence, and that's staging. So much of kind of how to recognize syphilis, but as well as how to interpret testing and how to administer the proper treatment really depends on this staging step. And so for the next little while, we're going to talk about the natural history of syphilis with an emphasis on sort of what symptoms and signs really are characteristic of each stage. This comes from our syphilis monograph from the New York City STD Prevention Training Center, which there will be a link to at the end of this presentation. Many of you, I'm sure, have seen something that looks like this in one place or another. And I think is a really good kind of graphic representation of the natural history of syphilis. We'll kind of go through each item here with a clinical case and try to kind of put it together all at the end when we talk about treatment. You'll see some other kind of phrases used to refer to some of these stages and other resources. Early latent is also called early non-primary, non-secondary, and late latent is called unknown duration or late. These are included here just for completeness, but for this talk, we will use the terms here on the graphic. So we will start out with Jack. He is a 24-year-old bisexual male who presents to you for an ulcer on his penis. He tells you it's been there for a few days, but doesn't hurt. And when you go to examine him, in addition to the ulcer, you find some inguinal lymphadenopathy. So how do we stage Jack? So this is primary syphilis. This is the stage of infection where the Treponema palladium bacteria invades locally, causing one or more ulcerative lesions, which we call chancres, that can differ considerably in clinical appearance. But here you have, again, kind of a classic one. For the most part, when we go through these stages, I will show you pictures and give you descriptions of the classic presentations of syphilis. But it's worth noting that syphilis is called the great imitator for a reason. And so many times patients don't present with something that looks exactly like this. And we'll talk a little bit too about some of the atypical presentations as we go. And so primary syphilis, again, is characterized by a kind of local invasion of the bacterium and one or more ulcers at the inoculation site. And so while you see kind of penile ulcers here, it's important to note and remember that syphilis can be inoculated anywhere. There's sort of abrasions of the skin that typically occur during sexual contact. And so that can be on the penis, that can be in the vagina, that can be in the rectum, that can be in the mouth. It's also worth noting that these lesions are painless classically and can go unnoticed for that reason. And so while many times people will notice external lesions, especially on the penis, ones in the mouth, vagina, rectum, often aren't really seen by patients at the time. Sometimes the only sort of clue to the presence of these might be some regional lymphadenopathy. Note that they can occur somewhere about 10 to 90 days after infection. And that these lesions are actually full of bacteria. They're highly infectious. And that they resolve on their own in about 1 to 6 weeks. And this is just one more kind of representation of an oral lesion here. Okay, so Jack really comes in here at primary syphilis. The 2021 STI guidelines do make a note just to remind us that not everyone, like I said, comes in with these classic manifestations. And so in addition to the single painless chancre at the site of infection, we should all remember to be on the lookout for folks who have multiple atypical or painful lesions at the site of infection. This study that's cited here actually comes out of a STI clinic in Melbourne, and that involved exclusively men who have sex with men, but noted that about 40% of people coming in with primary syphilis actually had multiple and or painful chancres. And so just something to keep in mind that multiple or painful lesions do not necessarily rule out syphilis. All right, so this is Jill. She's a 25-year-old assigned female at birth who presents to you for routine STI testing. She tells you that in the last 3 weeks, she's been in a relationship with a bisexual man who was recently diagnosed with syphilis. Actually, it's Jack. She tells you that she has no skin lesions, no rash at all, and when you examine her, you really find nothing out of the ordinary. So she feels and looks entirely well. And so this actually is an excellent example of what may be incubating infection. So syphilis has a pretty long potential incubation period, anywhere from 9 up to 90 days, before people will start to show any sort of symptoms. And this is, again, where that history taking becomes so important, because there may be nothing that would prompt you to think about syphilis unless you get that information. And so these people who have had exposure to someone with known diagnosed syphilis in the last 90 days, but have no symptoms, should be presumed to be infected, but in this incubation period, this asymptomatic period. and we'll talk about their treatment later. But again, they should be presumed to be infected at that point. All right, and finally, we'll talk about Jordan, and we'll spend some time with Jordan. And this is actually kind of taken from a patient encounter from one of my colleagues a couple of years ago that followed a pretty educational clinical course. So Jordan is a 30-year-old man who has sex with men, who started PrEP about 6 months prior to his initial contact with us. He came in today for a routine PrEP visit and noticed a relatively recent history of diffuse skin rash that has now faded without any persistent symptoms. But he tells you when you talk to him that about 6 weeks ago, he presented to an urgent care when this rash appeared and got sent home with a topical steroid cream. This is an actual picture that the patient provided permission for us to share of the rash. It was diffuse, non-pruritic, non-painful. He had erythematous macules and patches on his chest, axilla, abdomen, and all of his extremities. These are just some further pictures of just how diffuse that rash was. And this is really classic for secondary syphilis. This is the stage of infection that's characterized by localized or diffuse mucocutaneous lesions, much like the one described above, often with generalized lymphadenopathy. Here you can see the classic lesions turning up on the palms and can also be present on the soles, which can be helpful for distinguishing from other kinds of rashes. Other signs that sort of fall into this presentation include mucus patches, condyloma lata, and alopecia. And it's worth noting that the primary ulcerative lesion may still be present. So you can have kind of overlapping primary and secondary syphilis findings in your patients. And it can be worth going looking for that chancre just to help you as you're trying to diagnose folks coming in with a rash that looks like this. Like I said, secondary syphilis is characterized by bacterial dissemination and can have a number of dermatologic manifestations. This includes condyloma lata, which you see here, these sort of flat, warty lesions that typically occur around the genitals. It also includes alopecia, which you'll see a picture of on the next slide, as inflammation from the syphilis bacteria can often sort of surround hair follicles on the head. There are also systemic symptoms in secondary syphilis that include painless generalized adenopathy, low-grade fever, and fatigue. Secondary syphilis typically resolves spontaneously within about 4 to 8, typically presents about 4 to 8 weeks after infection and resolves spontaneously in about 6 weeks. It's important to remember that because there is sort of hematogenous dissemination of bacteria at this time, folks who have active manifestations of secondary syphilis are highly infectious. This slide just really goes through sort of the myriad other clinical presentations you can see with secondary syphilis. And so aside from the skin and mucous membrane ones that we talked about, the rash, the condyloma lata, the alopecia, there are mucus patches, which can be these sort of flat, I've seen sort of more whitish silver macules, plaques inside the mouth or on the tongue, or in the anogenital mucosa. It's worth noting that these can often be mistaken for thrush. There can also be these papules at the angles of mouth and nasolabial folds that are not so common. We talked about systemic symptoms like malaise and fever. And more rarely, you can see syphilis infecting the stomach and gastric syphilis, the liver, rarely causing kidney issues, including glomerulonephritis and nephrotic syndrome, musculoskeletal, including arthritis and periostosis. And one not listed here, but that I actually maybe saw last week, was someone who'd had some lung manifestations, in his case, a little bit of bronchitis. And so again, syphilis can look like many, many things. But in the case of secondary syphilis, usually these sort of external skin and mucous membrane changes are the most common clue. Okay, and so Jordan, when he kind of first presented to that initial visit with the rash, falls pretty squarely into the secondary syphilis category. But then we noted that by the time he came to see us for his PrEP follow-up, really his symptoms had essentially resolved. And that puts him over in the early latent category. And so folks who kind of have spontaneous resolution of their primary and or secondary, if they have it, syphilis manifestations, will gain a degree of immune control of the infection and become asymptomatic and enter this period of latent infection. It's worth noting that people in the latent stage will potentially go on to have sort of intermittent periods of bacteremia, and can have sort of relapse manifestations of secondary syphilis during that time. And so there can be some back and forth between sort of secondary and early latent disease, as well as some of the other manifestations that we'll talk about in just a moment. And so people in early latent disease still have risk of kind of new manifestations when, like Jordan here, they don't get antibiotic therapy at that time. And that brings us to now. So talking a little bit more to Jordan, he says that a few days ago, he felt like he had a hard time hearing the TV. He actually went to the ER and got seen by an ENT there, who noted on exam some asymmetric hearing loss and recommended an MRI. The MRI was unremarkable, and he was told to follow up outpatient. It's worth noting that in the actual case that inspired this, the patient was seen in the context of COVID, and so everyone's attention was really kind of directed towards that. When you talk to him today, he notes that since that time, he's also developed some difficulty with reading his homework. A thorough neuro exam reveals decreased visual and auditory acuity, but no other cranial nerve abnormalities. But you send him urgently to the ophthalmology clinic. And when you get a call back from the ophthalmologist, they note that they saw on his fundoscopic exam something called panuveitis. And so that brings us to some of the sort of more consequential and more feared manifestations of syphilis, which would be ocular and otosyphilis. So ocular syphilis, which we just mentioned, often presents as something called panuveitis, which can involve any structure in the anterior and posterior segment of the eye, including conjunctivitis, presenting with red eye and pain, anterior uveitis, optic neuropathy, retinal vasculitis, and all of these can lead to permanent vision loss. Similarly, with otosyphilis, we typically get cochlear-vestibular symptoms that include tinnitus, vertigo, and sensory neural hearing loss that can be unilateral or bilateral, typically has a pretty sudden onset and can often progress rapidly. Again, this can result in permanent hearing loss. I also just want to make a quick mention of other manifestations of neurosyphilis. So the ocular and otic syphilis that we mentioned before do fall under this category of neurosyphilis. What we typically often think of when we think of kind of neuro or CNS infections is something more like meningitis. And so syphilitic meningitis is a clinical entity, tends to be seen within the first year, and can be seen during primary or secondary syphilis. And so when we go back and look at that time course, you'll see that the sort of bars for neurosyphilis, ocular and otic syphilis kind of extend through the early secondary and early latent phases. It's really kind of similar to any other meningitis with headache, nuchal rigidity, photophobia. There can be cranial nerve deficits. It's worth noting that syphilitic meningitis doesn't have usually the same acuity as like a typical bacterial meningitis, but the overall manifestations are similar. There's a rarer meningovascular neurosyphilis that presents a little bit later, which I won't go through at length here. And then there are some of those late manifestations like syphilitic dementia or tabes dorsalis that we also won't go through. But just that it's worth noting that this category of neurosyphilis really does include ocular, otic, and meningitis, as well as an asymptomatic CNS infection. It's useful when evaluating people for potential neurosyphilis who are coming and presenting with symptoms of primary or secondary syphilis to have a way of systematically kind of screening and asking about symptoms that might pertain to one of these really kind of more serious diagnoses. This little questionnaire comes from King County in Seattle and their health department, and I find it really useful. It goes through questions about new trouble hearing or ringing in your ears, vision changes, as well as kind of questions around those meningitis manifestations that we discussed. And so this is something that I would recommend that everybody at least take a look at to kind of guide you when you're evaluating these patients. Okay, so at this point, Jordan seems to have potentially moved from early latent down into this early neurosyphilis, as well as, or I'm sorry, really early ocular and otic syphilis, which are all sort of components of neurosyphilis. Finally, we are going to talk about Jackie. She's 29 years old, assigned female at birth, coming to you to follow up after a referral that happened after a recent family planning visit, sorry, where she reported that she was considering becoming pregnant. Her OB at that time offered her comprehensive STI screening, which included syphilis testing, and she's been referred to you now for a positive result. A pregnancy test from that visit was negative, and you also get the history that prior syphilis testing 2 years ago was negative. She notes that she doesn't have any symptoms today and has a normal exam and really can't remember any history of symptoms that might be attributable to syphilis. And so she's really the case representation of latent disease. And it's important to know about latent disease. It's defined as kind of asymptomatic infection and is really divided into early and late with a sort of time point for that division of about 1 year. It's important to make that distinction because, like we discussed earlier, early latent disease carries this risk of relapsed or intermittent bacteremia, and that can occur in up to almost a quarter of patients, and that carries those manifestations, including those of secondary syphilis or CNS disease, and also runs the risk of infecting partners. That risk of relapse symptoms and infectiousness really starts to decrease around 1 year. And so doing everything we can to try to assess when that infection might have occurred is really helpful. In Jackie's case, we learned that her last negative syphilis test was about 2 years ago. And so we don't really have a good way to say when within those last 2 years, especially in the absence of symptoms, her infection occurred. And so she falls into this late latent category. So that's a latent infection, asymptomatic infection that could have occurred over 1 year ago. Some people might also term this latent syphilis of unknown duration, which really kind of fits her case. Okay, so that was a lot of talk about staging of syphilis and the clinical manifestations. And before we move on to testing, I just wanted to see, are there any questions? Taking a
So
quick...
Sorry,
go
Dr.
ahead.
McLean, there was one question that came in on the chat, and the question, I think you've reviewed it, but I'll just read it out to you, is how is secondary syphilis spread?
So secondary syphilis, like other syphilis, is spread by inoculation of bacteria into either sort of macro or micro abrasions on the skin or mucous membranes, typically during sexual contact. And so that can happen without any obvious ulcers. Though, of course, we talked about those syphilitic ulcers being sort of very full of bacteria, but can occur through things like semen, as well as, again, blood or bacteria that are close to the surface of the skin getting transferred through the skin abrasions. Anything else?
No, that was the only question so far. We just got another question, actually. Why is the duration of incubation 9 to 90 versus 10 to 90, which is CDC's guidance?
Fair question. And so the NYCPTC has used this 9 to 90. The CDC says 10 to 90. I think for clinical purposes, there's probably not much distinction there. And I'm not sure there's really concrete data to say 9 or 10 days is the sort of minimum amount of time.
Great, thanks. We'll take one more question and then I'll let you continue with your talk. And that question is, should all people with female anatomy have a speculum exam as part of the syphilis evaluation?
And so that is a fair question. I think you're kind of referencing looking for chancres that might suggest primary syphilis at that point. I'm not aware of any recommendation that would suggest that a speculum exam is required any more than, say, anoscopy would be required for someone having receptive anal sex to look for rectal lesions. Certainly, when people are presenting with symptoms in those areas, I think that would be indicated. But otherwise, a lot of the sort of treatment can be presumptive based on history. And then we'll talk a little bit about sort of treatment based on testing and the limitations inherent in that.
Great, thanks so much. And just as a reminder, if anyone has questions, try to use the Q&A box. It's just so helpful for us to track questions that way. Thank you.
Okay, so with that, we'll move on to testing. And syphilis testing is something that I think kind of confounds a lot of providers, and it can often drive sort of a lot of the questions that we get. And I just want to throw out there that that's not the fault of the providers or the other people trying to interpret these tests. They are inherently not sort of the ideal yes, no kind of tests that we would like to be able to offer our patients and try to be able to interpret for them. And so I'm going to walk you through some of the issues that kind of underpin that. And hopefully by the end, you'll feel a bit more confident getting a handle on what those test results mean and why we do it this way. Excuse me. Okay, so first of all, how do we test for syphilis? Well, I'll tell you one thing that we're kind of not talking about, and that is the testing of primary syphilis lesions for the presence of treponemes. There are multiple ways of doing this, including things like dark field microscopy, direct fluorescent antibody testing. Those two specifically are really not widely available. Dark field microscopy is something in the way of kind of a lost art, and most clinicians don't have access to that. The treponema palladium gnats, or PCRs, are used in some research circumstances, but there are no FDA-approved, widely available commercial tests. And so these really aren't part of our standard algorithms. What we do use, however, are serological tests. And serological tests fall into one of two main categories. There are the non-treponemal or lipoidal antigen tests and the treponemal tests. The treponemal tests are relatively straightforward. These look for antibodies that are reactive against the T. palladium bacteria, and specifically T. palladium rather than other treponemes. They're much more specific than the non-treponemal tests. Like other antibodies that we often check, they generally remain positive for life. And these have the main advantage of often being automated. Not all the treponemal tests are automated, but the enzyme immunoassays, which we'll sort of go on to talk about, often are, and that can present a real advantage for labs using these. The non-treponemal tests are a little bit more complicated. They actually look for the presence of antibodies reactive to cardiolipin, cholesterol, and lecithin. Those antigens are actually kind of present at high levels in the T. palladium bacterium, but they are also present at lower levels in host tissue. And so response to those antigens is due both to the bacterium themselves and also to host tissue damage during the course of infection. And so you do see some levels of false positives there. In one case series, it was up to 11% of positive tests. The advantage that these have is that the degree of reactivity actually changes over the disease course and after treatment. And so they can be really useful for gauging response to treatment as well as potential reinfection, whereas those other antibodies remain positive for life and kind of never change. The downside of these is, aside from those false positives, running these tests is typically a manual process, which requires some expense and person power, and also runs the risk of a little bit of subjectivity, which we'll mention. The tests that you might have seen in the non-treponemal category include the rapid plasma reagent, or the RPR, as well as the Venereal Disease Research Laboratory, or VDRL. Almost all labs for serum testing will use the RPR, and that's probably what most of you are working with. In the treponemal tests, there are multiple kind of entries. The enzyme immunoassay you'll see kind of frequently with one algorithm, and then the fluorescent treponemal antibodies and treponemal palladium particle agglutination are both manual tests that you may also see. And then chemiluminescence assays are also out there, but a bit less common. And now on to the algorithms. And this really is another thing that drives a lot of our sort of technical assistance-based questioning. There are now two main recommended ways of approaching using those treponemal and non-treponemal tests in combination. And so one is called the traditional sequence, which you'll see here. And then the reverse. We'll go through both. It's worth noting on this slide kind of the distinction between which steps along the way are manual and which are automated. And it's really probably that manual versus automated first step that drives most labs' decision to use one over the other. Like you see here, the reverse sequence starts out with an automated EIA. And so throughput with that is often much higher than going and doing a manual RPR on every single specimen sent for syphilis testing. And it's really more that kind of advantage of automation or not that drives most labs' decision to go with one over the other. So starting out with the traditional algorithm, and this is what we use where I am. It starts out with a non-treponemal test, in our case, a quantitative RPR. And if that's non-reactive, then you have no serologic evidence of syphilis and either presumably no infection at all, or potentially you're in that early incubation period of 9 or 10 to 90 days, and sometimes in early primary infection. So these tests are sort of incompletely sensitive to early infection and not 100% reliable in that case. And so in people who are presenting with things like chancres, it's really important to maintain that high clinical suspicion and not rely entirely on serologic tests. If that RPR is reactive, then infection is confirmed with one of the more specific treponemal tests. And so anyone from that category will do here. If that's non-reactive, then like we said, the people who have kind of a somewhat longer standing infection with syphilis, either secondary or later, and most often early, should have antibodies. And so the lack of those really makes it more likely that you got a false positive RPR for any of a number of reasons, including other treponemes, things like autoinflammatory disease, old age, any of those things that can generate a bit of inflammation and possible reaction to those lipoidal antigens. If you have a reactive test, then you have evidence of syphilis infection, and what remains for you is just to stage. So evidence of syphilis infection here includes current infection, but also prior treated infection. And we'll talk a little bit about how to use RPR titers to try to distinguish those. The reverse algorithm starts out, like we said, with an automated test, an enzyme immunoassay that's specific to T. palladium. And if that's not reactive, then you have no serologic evidence of syphilis. Limitations are the same as starting out with the RPR. This is not sensitive in the incubation period and less sensitive in the early primary infection. If it's reactive, that gets followed up with a non-treponemal test, generally, like we said, an RPR. And if that's reactive, again, you have evidence of syphilis infection and are left to distinguish current active infection or prior treated infection. If it's not reactive, then you actually use another treponemal test as kind of a tiebreaker. And so just something different from the first test that was used, and often one of these kind of more manual tests like a TPPA. If that's reactive, then sort of you have 2 out of 3, and that is interpreted as evidence of syphilis infection. If it's not reactive, and all you have is kind of 1 out of 2 treponemal test positive and a negative RPR, then that's thought to likely be a false positive. Okay, so that's sort of serologic testing. But what about CNS disease? And so neurologic disease previously always required diagnosis with CSF studies. The abnormalities of which would typically include some pleocytosis, so more than 5 cells in most patients, or more than 20 in people with HIV, elevated protein, which has limited sensitivity and specificity, and the CSF VDRL, which is quite specific, but less than 80% sensitive. And so this often presented a lot of kind of cases of equivocal sort of infection, and of course required a lot of lumbar punctures, which we would prefer to spare our patients. The 2021 STI guidelines actually have a couple of updates that let us avoid some of these LPs. And so for people with isolated ocular symptoms who don't have cranial nerve dysfunction, these are people who have gone to the ophthalmologist, have gotten that dilated exam, and they found that uveitis and said this person has something consistent with syphilis, and you have a serologic test that confirms they have syphilis. For those people, you don't have to do a CSF exam. Ditto for someone who has confirmed otic syphilis. The lumbar puncture and CSF studies in these cases really just sort of don't change management. They get treated with the same penicillin regimens as before. Also, prior recommendations stated that people who had a positive CSF exam, or quote unquote positive CSF exam at diagnosis, should get a follow-up LP at 6 months to demonstrate resolution. Now there's data to show that people who have had an adequate RPR response over that time really don't need that repeat CSF exam. There's just such a good correlation between the RPR response and CSF normalization. And this does apply to folks both without HIV and people who do have HIV who are on treatment. One other FAQ around syphilis testing that comes up is about reporting. And so syphilis cases, and this is, I believe, in New York, do have to be reported to the Department of Health within 72 hours of diagnosis. And sort of since the more recent uptick in cases, this was sped up to 48 hours. I know there are folks on this call from sort of other jurisdictions. The real bottom line here is that most labs, especially sort of large commercial or academic labs, will do this reporting. But if you're not sure how it works in your practice setting, it's always worth checking with the local Department of Health regarding reporting requirements and processes. Okay, so just checking our time. I'm gonna keep moving real quickly through treatment to leave us time for questions at the end. And so I see that there are some folks with some things in the chat and Q&A, and we will try to get to you. But moving on to treatment. Treatment is actually probably the most straightforward part of all of this, fortunately. There are really just a couple of drugs in sort of widespread use. And the backbone of syphilis treatment is really still penicillin, the same as it was in 1944. Resistance has really not been observed since starting treatment during that time. We know that because penicillin, or we think that because, syphilis is sort of a slowly replicating bacterium, that it needs really prolonged exposure to the antibiotic to get true elimination. And fortunately, long-acting benzathine penicillin G sustains blood levels for up to 7 to 10 days after just one injection. And so this is really our go-to. Unfortunately, there was a recent shortage of this drug due to some manufacturing issues. And so doxycycline got introduced as an alternative, use of which is primarily supported by some retrospective studies. In January of this year, the FDA made a decision to allow importation of a different brand of benzathine penicillin imported from Italy, which has relieved those shortages in a lot of places. And so most of what we'll talk about here kind of focuses on how to use penicillin for treatment of syphilis. And a couple of slides will also note the alternative doxycycline regimens. So, like I said, treatment is actually comparatively simple when compared to things like staging and interpreting tests. And so treatment is the same, in fact, for kind of the first 3 types of stages of syphilis that we talked about. So for incubation, primary, and secondary or early latent, the treatment is the same. 1 injection of benzathine penicillin G, and you're done. The alternative is doxycycline for 14 days. But it's really great that oftentimes, especially when staging is unclear, our clinical circumstances are also unclear, we can really just offer people, same visit, one-time treatment, and feel good that they've gotten adequate therapy. This does change when we're talking about CNS disease. And so this is kind of the major departure from what I was talking about before. For these people, we really think that we need to have still sustained but higher levels of penicillin to ensure adequate CNS penetration. And so for people with that ocular otic or neurosyphilis, they get 18 to 24 million units per day of penicillin G, aqueous crystalline penicillin G, either every 4 hours or by continuous infusion for 10 to 14 days. This is, of course, rather logistically more challenging than the one shot of penicillin G, but really essential because, like we talked about, the consequences of these can be permanent. There is an alternative that avoids the need for such frequent or continuous IV infusions, which is intramuscular procaine penicillin G plus oral probenecid. That oral probenecid has to be 4 times a day, and someone has to be in a scenario where they can get daily intramuscular injections. And so while this is certainly possible and is within the CDC recommendations, I think this is kind of a less common regimen to get used in clinical practice. Finally, like Jackie, our late latent disease, we said that penicillin replicates pretty slowly. We think that in late disease, late latent disease specifically, it replicates even more slowly, if at all, and therefore requires really prolonged exposure to antibiotics. This is mostly based on kind of expert opinion rather than such hard clinical data. But in this case, the recommendation is to have 3 injections of benzathine penicillin G spaced each 1 week apart. And the alternative doxycycline regimen lasts for 28 days. But that is really it. The sort of questions that come up around this regard sort of acceptable days between injections or delayed injections. And so if people are getting treated for sort of late latent syphilis, the majority of the time, we say interval between 7 and 9 days is preferred. So once a week is the standard, up to 9 days still falls within this kind of preferred window. But an interval of 10 to 14 days kind of might be acceptable before restarting the sequence of injections, all kind of based on expert opinion. And in your jurisdiction, you may want to check with the local health department for their policies. The exception is in people who are pregnant. And in that case, the optimal interval is 7 days. Up to 9 days is okay, but after 9 days, it's really not okay. And it's recommended to repeat the full course of therapy at that time. Also important to talk about is repeating treponemal tests to look for improvement in infection. It's recommended at least 6, 12, and 24-month intervals. And you're looking for a decrease in titers by 4 times. And so that should happen by 12 months in most folks and 24 months in people with late latent disease or who have HIV. And we'll go very quickly through kind of what that means. So syphilis titers are reported like this, or RPR titers specifically are reported like this. And what you'll see is kind of a set of ratios that increase by 2 each time. And this comes from the RPR test and the way that it's done, which you can see here. So this is a test card. And the test itself consists of combining patient serum with charcoal particles that are coated with those antigens, the cardiolipin and lecithin that we talked about, and then mixed and watched for sort of clumping called agglutination. And on each successive circle, they're diluted by 50%. And the positive titer that gets reported is kind of the highest dilution that still has some of that agglutination. And so here it's around this 1 to 64 mark. You can see here that there is some subjectivity in reporting these and deciding kind of when you go from some agglutination to none. And for that reason, it's actually what we call a 4-fold change that's required to sort of say that there's been a clinically significant change and therefore call something new infection or successful treatment. The way that looks in practice is when you have sort of 1 dilution change, that's a 2 times increase or decrease in titers. And like we said, it's kind of 2 adjacent circles on that card and might be a little bit hard to say what's agglutination versus not. What we're really looking for is, for example, a change from 1 to 8 to 1 to 32. this is 2 dilutions, or what we call a 4-fold change. I really think when we're talking about this can be confusing, folds versus dilutions. The only thing that's worth taking away, in my opinion, is this fold change, which is just multiplying or dividing by 4. That's kind of the minimum change required for clinical significance. And so a 4-fold increase here would represent new infection, someone who had a prior RPR of 1 to 8 following successful infection, who goes up to 1 to 32 has a new infection. And similarly, someone who comes in new diagnosis of syphilis with a titer of 1 to 16 and goes down to 1 to 4 after treatment is felt to have successful treatment. This slide addresses one of the questions from before about how syphilis is transmitted. And I would just urge you all to reference the monograph that we provide to think about kind of how long prior to diagnosis your patient may have been potentially infectious, and to enable sort of the best partner notification and testing and treating depending on that. We also often get questions from patients and providers after syphilis treatment. When is it safe to have sex again? The standard recommendation is 7 days after the treatment is over, and for folks with primary syphilis after the sores have completely healed. All right, so just a few takeaway points. Syphilis cases are rising, so this is a really important, timely issue. Think about kind of testing your patients if there is risk of exposure, and knowing that requires taking that good sexual history. Also, I would say, as a note we didn't mention before, but think about just testing for syphilis when testing for or screening for other sexually transmitted infections. There are some sort of more frequent, more intensive screening recommendations for things like gonorrhea and chlamydia, especially in younger women. In sort of the current epidemiology, it's probably just worth lumping things like syphilis and also HIV into those offerings of tests. Knowing which syphilis testing algorithm is in use at your institution is really helpful to know about diagnosis and staging. And then treatment is based on the stage of disease. Remember that neurologic, including ocular and otic manifestations, can occur anywhere in the sort of primary and secondary and early latent stages. And it's important to screen for those because it does dictate treatment. And most of all, identifying syphilis cases, especially those with atypical presentations or with no symptoms, requires maintaining a really high index of suspicion. And so we all need to be just a little bit on the lookout. But with that, that's everything. These are, as promised, links to the syphilis monograph from the STD-PTC here, as well as reference to the STD clinical consultation warm line, where we would be happy to answer any questions about your patients. And so that is it. Thank you again, everyone. I will do everything I can to start talking about the Q&As here.
Well, thanks so much, Dr. McLean. And we just wanted to point out that our medical director, Dr. Natalie New, is also attending this webinar, and she's been answering a lot of people's questions. So really appreciate that. But there have been a lot of questions. And so, Dr. McLean, I'm just going to start with the first one. And the question was, if Jackie was a partner to early case, wouldn't she be non-primary early case?
And so I am trying to make sure that I'm keeping the names of all of our patients straight. As I recall, Jackie was the person who had infection that we deemed to be in the incubation period, I believe, whose partner was an early case. And so in terms of kind of the nomenclature around this, the early non-primary, non-secondary is typically used to refer to what we would otherwise call early latent disease. So that's people who probably had infection and then kind of didn't notice either some of the symptoms like a painless chancre or something like that, and then have progressed a little bit longer. The clinical upshot is mainly that somebody who has been exposed, you would absolutely not expect to have a reactive serologic test, whereas somebody who is maybe in that early latent disease probably would. And so you just have to maintain that suspicion, get that history that someone has been exposed to someone with confirmed syphilis, and treat them accordingly when they have infection in the incubation period.
Thank you so much. So the next question, and let me know if you just want to repeat it, it's in the Q&A box, is how long would you wait to repeat an RPR if worried about re-exposure? I have a client that was treated in 2015. Normally her titles are 1-to-1. Now she is a 1-to-2. Would you treat assuming a new infection or repeat a test in a few weeks? She has no symptoms.
Yeah, great question. And so this is one of those things that, like we said, kind of gets back to the little bit of subjectivity in the RPR. And so that change from 1-to-2 by itself doesn't necessarily constitute a clinically significant change the way that it would be if it went from 1-to-1 to 1-to-4. That said, if this was someone with a history that was really suggestive of kind of potential for new exposures to syphilis and you wanted to test them again down the line, that would be entirely reasonable. A lot of intervals are sort of every 3 months or so. And certainly you might think about doing sooner if she did have symptoms. But in general, to answer your question, for the 1-to-2, not necessarily. If you had suspicion for a new exposure based on the history, then yes, would repeat down the line.
Great, thanks so much. The next question is, have there been any studies yet to show if doxycycline has been effective as penicillin?
So not to my knowledge, actually, and I think there will be hopefully some retrospective data that comes out of this shortage and sort of the wider spread use of doxycycline in that context. But at least as far as I'm aware, there is no like head-to-head comparison at any point in the past of doxycycline and penicillin.
Great, thank you. The next question is, I have a patient that is serofast at 1-to-64 for up to 4 years now. She has had CSF testing, 3 doses of penicillin, and 28 days of doxy. It's actually not a question with that. It's more of a comment. So if that person wanted to add on to that, that would be great.
And
So it's,
yeah, and I see no specific question. People can be serofast. I'm not aware of anything that says that folks who have a appropriate decrease in titer after treatment. I don't know where she was before that 1-to-64, but as long as she's had sort of an appropriate decrease in titer preceding that, I'm not aware of anything that says that persistence of a relatively high titer, which is maybe what you're getting at, should cause kind of additional concern.
okay. Maybe we could take one more question. And the question is, what would you do if a patient is in a relationship with a person who tested positive for syphilis in December 2022, but tested negative when they tested in December 22 and April 2023? The patient's partner did not receive correct treatment in 2023, but they have still been sexually active.
And I'm having to try to put together some of those dates on the fly just a little
Yeah,
bit.
sure.
But it sounds like folks who have been partners and sexually active together for quite some time, and the partner, you said not appropriate treatment, but some treatment went from kind of a positive test to negative. I probably would have to have more information to answer that question. I think sort of starting by testing the patient in question, your patient, would be the first move. And, if they test positive for syphilis and it's the first new positive test for them, then you could treat them kind of accordingly. And oftentimes, I'll say kind of on a broader scope, when people test positive and it's just kind of unclear when they might have been exposed, then at that point, we tend to lean towards presuming kind of a longer exposure. Again, the category is kind of syphilis of unknown duration. And when we can't prove that it happened within something more recent than a year, they get kind of the longer course of penicillin. Let's say if that answer maybe isn't adequate and you want to address it further, feel free to send it in via the Clinical Consultation Network, and we'll spend a little more time thinking about it.
Thanks so much, Dr. McLean. I was just going to suggest that, and that link is actually in the chat right now. If anybody wants to use that, we are happy to look at those questions. We are at time, so unfortunately, we do have to end today's webinar. It looks like we got to most, but not all questions. Again, if you do have additional questions, you can submit them through the clinical consultation line, which is listed in the chat. We appreciate everyone attending today and hope to see you on a future webinar. Thanks so much.